chapter is on change management. And I think change management is essentially foundational of what we do as CMOs. I think we're change agents, essentially. We're physician change agents.
Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast brings you stories and wisdom from some of the best CMOs in healthcare today. The leaders on this show face some of the toughest challenges in healthcare today, and they will share with you their insights about the role and the responsibilities that come with the title of Chief Medical Officer. Today, our guest is Dr. Stephen Brast, the Executive Vice President and Chief Medical Executive at Harris Health in Houston, Texas. Dr. Brast grew up in Canada, and he earned his undergraduate degree from McGill University, where he also attended medical school and residency, ultimately specializing in neurology. Later, he completed a fellowship at Harvard University in multiple sclerosis and another at Boston University in sleep medicine. Stephen, welcome to the show.
Thank you so much. We really appreciate it.
Absolutely. It's a pleasure to have you on the show. Do you remember anything about the first time you and I met?
We were at conference together in conference.
Do you remember where?
In Boston?
We were in Chicago.
Chicago.
We literally met for the first time, both of us, on a panel hosted by American Association of Physician Leadership, and our moderator was Dr. Mark Olsick.
Yes.
And do you remember how afterwards we sort of formed a gang of chief medical officers and caroused the town of Chicago that night?
Yes, I remember.
Yeah, and what happens in Chicago stays in Chicago, right?
That's right.
That's right. So we won't get into that on this show, but it is a pleasure having you. You have achieved quite a lot in your professional career, and I suspect you've learned a few things worth sharing with our listeners about your journey becoming a chief medical officer.
So initially, I went to medicine. Like I said, it wasn't for administration. I did not even know what a CMO was. But as I became more and more involved in quality and safety, it became more intentional. And I said, this is what I want to do. This is what I want to become. How do I do it? And it wasn't very clear to me. The hardest part about getting into these type of roles is the first step. And I needed to first gain credibility. And I think having the experience of working in quality and safety at the both clinic level, the hospital level, getting involved in finance, and then formalizing my education through an MBA, through a master's of health, were really helpful for me to leverage credibility when I applied for these different opportunities. And it was intentional at that point to want to apply for that administrative position.
Many of the CMOs that I talk with around the country share similar stories of never really contemplating an administrative post within the house of medicine. And most of us do that within hospital and acute care settings, although it certainly happens in our clinics, in our ambulatory settings, and also in the health plan world. But it is not well understood at the beginning of our career when we become sort of competent beginners through our medical school years and then become a competent clinician through our postgraduate, our graduate medical education. And again, it is not something commonly known, but it is always fascinating when people sort of get that calling, get that notion, I'm going to do more. There's more that I can do, and there's more that I will do. So it's a great story of yours. You obviously put time and energy into the preparation of the role, and that's something that you and I and Dr. Olsick and others have spent a lot of time talking about the last few years. And I believe that this platform will help younger physicians begin to think about going into roles and shape the impact of the care that's delivered in a variety of settings. Well, let's move on a little bit. I can separate people into three categories. It's just an easy trick of mine to begin to work with people. And this is not my idea. It came to me from another source. That people can fall into three categories: that of being analytical, aggressive, or diplomatic. And I would like to think that there are three physician leader archetypes in the same way: Dr. Osler, Dr. Michael DeBakey, and Dr. Anthony Fauci. And I want to know which category or archetype would your coworkers say most fits you? Not what you think you are, but what they think you are. Do your best here.
So I think that if you speak to my coworkers, they would say I'm in the diplomatic category. I really view collaboration as key. Well, you often deal with the medical staff who don't report to me as the chief medical executive. They are the governing medical staff. And we often have to do change management and invoke a lot of change with physicians who don't report to us. And the best way to do that is developing relations, getting to really listen to them, their thoughts, getting their buy-in, hearing what their barriers are to the change, following the loop, their concerns, making sure it's a two-way street, that when they have problems, that you address their problems and close the loop. So when you come to them, they are more receptive to helping you. And I believe that the only way to get things done is through the diplomatic approach, actually. And I view that as key. And one of my key strengths is my collaborative approach, my style. And I think that has been the way I've been successful, actually, in my career, is through the diplomatic approach. And that's what I view as a model, is someone who's diplomatic, dealing with these very sensitive issues that affect healthcare and patients' lives.
I would agree. I think it is of several different archetypes, some that we didn't mention. That is a very important type of role to have with your medical staff, to be very diplomatic, to understand what their concerns are. And as far as I'm concerned, I too would say you are very diplomatic. I have leaned on you for counsel and guidance, and you are very helpful and very diplomatic. Very wise and very fair. So I'd like to be part of your medical staff one day, but again, another conversation for another day.
Now, I do have to say one thing. When there are certain situations where you have to move from not authoritarian, but more different style of leadership in an emergency situation where time is of the essence and you don't have time necessarily for diplomacy. So my leadership style may change. Depending on the emergency at hand. If there's a crisis, you may have to use different approaches in leadership style, and that's normal, that you tailor your leadership style to what is the issue at hand. But in general, I would say I've been most successful when it is diplomatic style.
Those that study organizational psychology and leadership and management would absolutely agree with you. We have our normal tendency, or we tend to a particular style, and then we have our adaptive style.
Right.
And really good leaders, the analogy that was presented to me once was like playing golf. You have a variety of clubs in the bag, and sometimes you need the driver, sometimes it's just a 5-iron, and sometimes it's just a gentle putt to make things work in your favor. So having different styles that you adapt to when the situation requires it. And look, physicians are trained the same way. There are times where we can be contemplative, thoughtful, diagnostic, and there are times where we simply have to make a decision, period. So let's switch a little bit, and we're going to come back to some of that leadership ability that you have later in the interview. Who might you say was influential to you in the process of preparing as you pivoted towards this role, and both in California and in Texas? Did you have any particular role models or mentors? And you do not have to mention names, but I'd like to hear a little bit about that.
There's two mentors that I'm delighted to mention and honored to mention, actually. One is Dr. Michael Bernstein, who was the California Regional Chief Medical Officer at Providence Health Science, and also was the Alaska Regional Medical Director. And he mentored me while I was in California, and I still am in contact with him. And he really was a model for integrity and what you need to do despite what the situation is going on. And he provided me guidance, put and thoughts on how to advance my career, what is in the best interest of my career, uh, regardless of what was going on in the organization. He always maintained solid advice for me. And then the second person is Dr. Hoda Asmar, who is the system chief clinical officer at Health Science over the entire system, who I work with closely in Adventist Health. And again, it's a role model for integrity, collaboration, and essentially was there to help me overcome barriers. She provided advice. She was held me accountable. Favorite statement that I always repeat is, at the end of the day, it's a result that matter, Dr. Brass. She did. So despite what was going on, whatever barriers I encountered, used to say that to me. They reminded me that at the end of the day, it's the results that matter. And I still am in contact with her as well. And she has served as a mentor and model for me.
You know, that's extremely insightful, and I'm glad that you recognized and honored both of those individuals. To your point earlier about the leapfrog scores, and we all have various opinions about the way that we are graded by third parties, but the bottom line is outcomes do matter. They matter for our patients, they matter for our systems, they matter for our staff. And physician executives get that as well as anybody, because again, in our training, we are seeking to understand the condition and or the prevention of such a condition, and to get to an outcome. We don't do it just for the sake of spinning wheels, right? We're trying to reach a result, an outcome. So we're blessed to have you in that role. Would you say was the hardest event that you have faced, whether in your old role or in your current role, and put the pandemic aside? We've all faced it, and it's been talked about. But what was the hardest event you have faced? And I know you've had a few, so I want you to pick one.
So I want to talk in general what I feel to be one of the hardest issues I deal with as a chief medical executive. And I think that is in general. And one of the hardest issues that we deal with is making decisions as a chief medical executive that are not popular or widely accepted. And I think everywhere I've had to do that as a chief medical executive, whether it's restructuring a team, implementing a controversial strategy, cutting costs to ensure long-term stability, these decisions can often alienate colleagues, physicians, other stakeholders, and it really tests the leader's resolve as they have to prioritize the broader strategy of the organization. And you have to have that vision, the long-term vision, over the person's approval that happens in this situation. And it can lead to self-doubt, but you have to maintain focus even if there's criticism, because otherwise the strategy can't move forward. And your success as an executive really hinges on that ability to stay committed despite what is going on in the organization, despite what people are saying to you, even when there's resistance or dissent. And I think that as a chief medical executive, that has been the hardest. And not everyone's going to like you. And that if everyone loves you, that means maybe you're not doing your job. Because
or you're not on planet Earth, because
right.
I haven't found a place where everybody loves anybody.
And sometimes people are not necessarily going to like you because of the changes you're making. And you have to realize that you're not going to please everyone. And dealing with difficult choices has been one of the hardest things for me. I've had to realize that not everyone's going to like you. Even if you present it in a diplomatic way, a professional way, you're still going to potentially have people who don't like you.
Absolutely. And, we become, as we go through our decision making to become a physician and study all the prerequisites and thankfully get to a medical school and go through that process and train and then take care of patients, we are really fortunate that we can remain in that bubble, because most of the time, when you walk into a patient's room or a family's room, even if the patient is nonverbal, there's a respect given to the physician. There's in fact, sometimes they may absolutely dislike you, but they are reluctant to show it out of concern for what is really at stake. But when you're not practicing, you don't see that. You're not shielded. You get the full on, full court press. And I was taught that about a third of the people are going to like you pretty much all of the time, and about a third of the people are going to dislike you pretty much all of the time. And you learn to manage that messy middle, that middle group that don't quite yet know what opinion they have to take. And you will always have critics and people who are far down on that bell curve, but you can't spend all your time there. And if you can move the majority of people and recognize that you just simply can't please everyone, but if you please most of them, you achieve this success. Would you agree?
Yes. And there's a famous quote that I want to share with you, that the quote is, if in leadership you want everyone to like you, don't be a leader, sell ice cream. Yeah. From Steve Jobs. And,
That might be the title of this show.
Right.
So that who can
Steve,
we quote? Steve
from Apple.
Jobs.
Yeah.
Not an insignificant human being by any stretch of the imagination.
And I really believe that's true. And that's really true, that in leadership, you have to deal with the complex issues that are not always popular.
Agreed. Absolutely. Well, one of the things I wanted to ask you is if you could characterize what was the biggest fire that you had to put out, and how did you put it out? Hopefully you were able to put it out, and clearly your ice cream would have melted in the moment, but notwithstanding that, what was the biggest fire you have faced?
I think one of the biggest fires I've faced in every organization I've gone so far as a chief medical officer is optimizing the peer review process. All of my entrees into chief medical officer, into the organization, were always a CEO saying, I need the peer review problem addressed. And the problem is that peer review, when I was brought on to all of these places, was suboptimal. The physicians didn't have trust in it. It wasn't being used to maximum efficacy. People didn't have faith in it. And peer review is extremely important to monitor safety. It's a condition of participation requirement. It's a joint commission, DMB requirement. And if the physicians aren't using it effectively or don't have faith in it, feel that it is punitive, it's not going to be regarded well. So one of my biggest challenges each of the organizations I come into is how I manage to change the culture and change the peer review processes to make it more effective, not educational rather than punitive, but still having an impact on quality and safety for the organization at hand, and ultimately for our patients. And it's very hard to change peer review processes and get physician buy-in. And like another quote is that culture trumps strategy for breakfast. So you need to understand the culture of the organization, the culture of the medical staff, their concerns, and really get their buy-in in a diplomatic way in order to make those changes to the peer review process to make it more effective.
Yeah, I would agree with you on that as well. What are some of the key leadership tools that you have used in regard to changing peer review? Like we talked about the golf club analogy. What kinds of tools have you been using?
So I think that first of all, I like to think of the Cotter's 8-step change management steps of change management, which I have previously written about in the CMO guidebook published by Mark. My chapter is on change management, and I think change management is essentially foundational of what we do as CMOs. I think we're change agents, essentially. We're physician change agents. And understanding the 8 steps involved in change management, understanding also where physicians are on the change curve. That's another tool that we use. It's called the Kubler-Ross change curve. Kubler-Ross was someone who studied dying and looked at the impact of death and how people deal with dying. First, there's denial, there's anger, then there's, depression, then acceptance. And it's similar to change. And essentially knowing where the physicians are on the change curve can lead you to understand, or where the organization is on the change curve, to know how to react and what support you need, where you are, and how fast to go change. And the Cotter's 8 steps is a model that I previously used. And essentially the model encourages you to, have a vision, communicate, celebrate the small wins, remove barriers, keep some metrics to allow for accountability, keep on repeating what your vision is in the long run. And it's really well designed. And I think it has been very effective as one of the tools for the change that I've implemented.
Um, I'm going to make a plug for your skill set. And if anyone is looking for a speaker on a wonderful approach to change management, it would be Dr. Stephen Brass, who I have been in the audience for that presentation, and I have begun to adopt the concepts that you raised, particularly as I worked in oncology and I was hospice and palliative care certified as well, and learning about death and dying as part of my career, and then applying the Kubler-Ross elements into change management is extremely insightful. And you were the first person to bring it to my attention. And I would encourage our listeners who are going through change management to give Dr. Brass a call, and he will walk you through an enlightening approach, which will save you a bit of heartache. It's hard enough as it is. So well done, sir.
Thank you. I find it kind of, the other day, my chief compliance officer and I were texting back and forth, and we were hearing one of our physicians sort of get upset with the change that we were anticipating. And I texted her, I said, where do you think he is on the change curve? On the Kubler-Ross change curve.
Yeah, we won't go any further, but that was excellent. Excellent. What do you think is the hardest aspect for you personally, as a person, as a human being, of being in the role?
I think sometimes, two things. I think number one, you have to learn to deal with the gray. There's not black or white in this, in areas that we deal with. There's not always a black or white answer, and you can't be so regimented in how you're going to approach a situation. You need to be agile and adaptive. And I think that's one thing that I've grown to be better at as a CMO is being more adaptable. I used to be very much more, black or white. And I realized that to be successful, you can't be black or white. There's shades of gray. You're not always going to have all the information you need to make your decision. You sometimes have to make decisions with incomplete information. That's the first thing. And then the second is you're going to have to pivot and adapt and be agile and nimble. Sometimes you're going to come across with your action plan, and then you're going to see your action plan either fail or not go out exactly as you anticipated. And whatever barriers that may have come up or situations that have arisen, you're going to have to adapt. So you have to be adaptable and willing to make those changes and be very nimble. And those are the two areas that were growth for me in my role, in my personal growth, is being agile and adaptable, and being aware that not everything is, you're not going to have all your information. You can't sit there and have every single data point in order to make the decision. Although we're very data driven, I like to be data driven. Decisions have to be made sometimes without all the data.
I'm gonna put you on the spot with a quote, and let's see if you can identify who said this. Now, I won't get it precisely correct, but everybody has a plan until they're punched in the face. That would be the indefatigable Mike Tyson.
Mike Tyson.
Yes. So you're right. You can come up with a really brilliant, well-designed approach to a situation, and at the last minute, or for reasons that are unexplained, it goes sideways, and you have to be ready to adapt on the spot. Definitely. If we had some sort of time machine, what would you say to your younger self about becoming a chief medical officer or a chief medical executive?
I would say it's an amazing opportunity. I would say that maybe in medical school, have you studied some quality and safety? Have you studied medical school, um, medical staff governance, which we didn't have an opportunity to study in medical school? Have you studied finance and accounting? I know that you yourself have written a great book on finance and accounting. Many of our physicians graduate these days from medical school and residency without having the word finance or accounting is not on the curriculum. And it's very unfortunate because then you have to either go out and practice or you have to deal with finance and accounting in your administrative role or in private practice and you have no knowledge of it. So I would have said to be a more holistic learner earlier on in my medical school and study things outside of what was just being taught in medical school in order to be a more well-rounded person would have been really, really helpful, I believe, in going back in time. It is that additional education that is unrelated necessarily to like neurology or neuroscience, but the areas that impact medicine indirectly.
Yeah. As you know, I was a chief medical officer, and now I work in medical education and leadership development. And that is a well articulated struggle in undergraduate medical education. And there are people that are putting a lot of thought and energy into how to bring that into the curriculum or as extracurricular activity. There are certainly plenty of young folks who will choose a practice environment where that is not the most important thing, and that's wonderful. But there are plenty of others, whether they choose an administrative post or not, that they need to have an awareness of this environment. And 40 years ago, your need to understand that environment was trivial. You could walk out and things happen, and people took care of things for you, and so on and so forth. Um, that is not the universe we live in today, and we need to approach that with some serious dialogue. Um, what do you think is the biggest fire in healthcare in general, in your own opinion, right now? And what would a chief medical officer do about that, if anything at all?
I think that one of the biggest fires that we're dealing with right now as a chief medical officer is we're dealing with physician burnout. Actually, is one of the very big issues that we're dealing with. If you look at the literature, 50% of our physicians report being burnt out. Many of them reporting wanting to retire and early due to the stress of the practice. And there's several areas that have been reported in the literature to contribute to that. Some of it is personal choices. Some of it is administrative burden, regulatory stresses, electronic medical record. So I think it's multifactorial. I say there's personal responsibility of how you do your work-life balance, and then there's how the system is treating the physicians are two areas. What we have done at Harris Health, I'm very proud of because I view this as a very important topic, physician burnout. And I like to call it focus on physician wellness rather than focusing on the negative. We actually have, first of all, we have a committee, a physician wellness committee. That's the first thing, a professionalism wellness committee. But secondly, we have a medical staff engagement advisory council where I meet with our front of the line physicians. There's no chiefs of staff, there's no medical directors. It's our frontline physicians from both schools on a quarterly basis. And we get their feedback on what is going on operationally that is frustrating to them. And what can we do to address some of these issues? Some of it are, I call it short-term wins, and some of them are long-term wins. Some of them I can't address, but the short-term wins, I definitely make an effort to address. And I come back to them and say, hey, you brought this up last time at the meeting. Look, we closed the loop on this. And I show them. I think that's really crucial with the physicians. So I'm trying to address some of the burnout issues through that approach. In addition, we do a physician engagement survey every year to learn in a confidential fashion what are some of the opportunities that they may not want to share. And it hits all of our medical staff. We had a great response this year, a 50% response rate, which is fantastic for a survey for physicians that's blinded and voluntary. And we had amazing responses. Our physician engagement scores have improved over the past 3 years. I'm really proud of that. And they have provided feedback, both positive and opportunities for improvement, how we can make our health system even better functioning. and that has been really helpful, is this medical staff engagement advisory council, and then this physician surveys where I'm getting guidance from them. And I have created action plans with my team to address these issues relating to burnout, or not necessarily the burnout, but to the practice, making it more streamlined, making it more efficient. How do we make it so that this Harris Health is the best place to practice medicine in the country? That's what I always say. My goal is to make Harris Health the place where you want to bring your mother or father, brother, or sister. And that's where I believe it is now. It's somewhere where I would feel comfortable admitting my mom or dad to the hospital. I've brought my family members there for care because I have such confidence in the health system, and I'm proud to say that. And I think I want all the other physicians to feel that way as well, that they could bring their parents, their brothers and sisters, their children to the health system. And they're so proud of the care that they provide there that anyone in their family could get treated there. And that's the ultimate goal. And it's by getting their feedback and their input. And that, I think, can help deal with some of the burnout issues, is having a voice, and some feedback, and what are the things that we could do at a system level. The second area that I think is a big hot area in medicine is artificial intelligence. I think that we are working at Harris Health. We started this year a tech governance committee, and we have an AI subcommittee related to AI. The AI is going to change the way medicine is practiced, the way we interact with each other and with our patients. And it's already being rolled out across the country in different ways. We are in the process of going back to foundation with our Epic, and along with that will be some new artificial intelligence tools that will be very, very helpful for us to be implementing. So I think it's instrumental for us to be implementing artificial intelligence techniques, and different technology, and keeping up with that in order to ensure that we're practicing in the best way possible at the top of our license, and keeping in sync with what is going on in the world of technology, so that we're practicing the most modern way, efficient way possible. So I think that is another big area for medicine that we have to keep up with.
I would agree with both of those things. We both know that there are millions of opinions on burnout, but when it comes to healthcare, there's only about 1 million reasons that matter, and that are the 1 million licensed physicians in the United States today. And a fraction of them don't practice medicine. You and I don't practice medicine anymore. So maybe there's about 750 or 800,000 voices that matter. And I applaud you again for giving a voice to your medical staff, because that's where physician executives can make a powerful impact. Burnout, I teach in my academy, is a occupational hazard, and you would no less leave a spill or a fall risk or a chemical agent out for people to get hurt with than you would set up systems and processes where people are feeling the occupational impact of that hazard. And AI hopefully will do two things: lessen some of that hazardous condition, augment the work, and potentially shine a light on some of the things that we should stop doing. We can put an ambient scribe in the room, but we're still filling out a document that supersedes what we really need from that document. It is a longer conversation, but I think AI may actually shed light on things that we need to change systemically and structurally. Well, this has been a great interview. Being a chief medical officer is no small task, and it takes intentional preparation, as you've described. And although some of it feels like a trial by fire, in fact, my old boss used to coach me and tell me that it is like a career in firefighting. You go to firefighting school and you train and you drill until you're ready to fight a fire. Put on a uniform and you start out as a fireman. And one day, maybe you find yourself being called a squad leader or a captain, and then perhaps becoming the fire chief. My boss always told me you cannot be a fire chief, though, without first becoming a firefighter. Do you agree with that, Steve?
Yes. And some days, Lee, I feel like I'm fighting fires every single day of my life.
Yep, that is a big part of our role. And that's why I call this podcast The Fire Chief.
Yeah.
It is something that with leadership and skills and tools and understanding where the ice cream is going to melt will
Right.
put you in a great position to be a great chief medical officer. As usual, it's wonderful talking with you. It was a pleasure to have you on the show, Steve.
Thank
You
you.
have been listening to the Fire Chief Podcast, the only podcast dedicated to the chief medical officer. Want to learn more about what it is like to be a CMO? Want to be on the show? Email me at leescheinbart@gmail.com or connect with me on LinkedIn. You can also listen to the podcast on Apple, and you can watch the videos of the shows on YouTube. Our show's website is thefirechief.podbean.com. I love talking with CMOs from all over the United States, so please connect with me, leave reviews and your comments, and please share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.